Good evening, guys. This is Dr. Bass. We're going to be covering junctional rhythms and SVT rhythms in our EKG lecture today. The first thing we're going to talk about is the actual anatomy, physiology, and the function of the AV junction. So the first thing is some terminology. When we're talking about the AV junction, we're talking about two things. We're talking about the AV node and we're talking about the bundle of His. So if you remember when you did your initial lecture in EKGs, and of course all of your physiology that you've had cardiac-wise in the program, the AV bundle and or the bundle of His is the only cellular connection between the atria and the ventricles. So the bundle of His, together with the AV node, makes up the AV junctional tissue. That tissue has an intrinsic heart rate of between 40 to 60 beats per minute. And what that means, obviously, is if this particular node, if something happened to the SA node and this node has to pace the heart, it would pace it at a rate of 40 to 60 per minute. That's the intrinsic rate of the AV junction. If the SA node fails, the AV junctional tissue can control the heart rate, as we said. The other really important function of the AV node and the bundle of His, or the AV junction, is it actually slows down that cardiac impulse, that action potential that's coming from the SA node. It slows it down and holds it for few tenths of a second in order for atrial contraction to occur. So you've got the electrical impulse that travels throughout the atria that depolarizes the atria. And once they're depolarized electrically, you're going to have mechanical function, which is contraction of the atria. In order for that atrial contraction to be effective, it needs to take place, obviously, before the ventricles contract. So the function of the AV junction is to slow down the cardiac impulse. So we're going to start with the basic junctional rhythm. We're going to identify junctional rhythms, the appropriate monitoring, treatment, and nursing implications. So the junctional rhythm overview. First of all, the impulse originates at or around the AV node and the bundle of His, which is our AV junction. And this is occurring typically during some type of SA node dysfunction. The pacemaker cells in the AV junction, which we've already said, fire at an intrinsic rate of 40 to 60, then become the pacemaker of the heart. What this means is you get retrograde conduction. Normally, obviously, your impulse starts in the SA node and it follows the normal pathway to the left atria, the right atria. We have all of these pathways that bring that impulse down to the AV junction, which then holds it and allows for atrial contraction. In this particular situation, what's happening is the impulse is originating at the AV junction. So the impulse is going to be, sorry, I'm trying to give you some, the impulse itself is going to originate in the AV junction or at the bundle of His, and therefore is going to travel retrograde up through these conduction pathways in a backwards manner, essentially. And what that means is if we have retrograde conduction, we're going to see an inverted P wave in the inferior leads, particularly leads 2, 3, and AVF. In lead 1, sometimes the P wave looks sort of isoelectric. And as you'll find with junctional rhythms, we're going to talk about the P waves can be inverted, missing, or they can be before, during, or after the QRS. So the characteristics of junctional rhythms, the heart rate is 40 to 60 beats per minute, and it's regular. In terms of the waves, the P wave can be inverted, negative, deflection, or absent. It can occur before, during, or after the QRS complex. The QRS is present and regular, and the T is present. If we look at our interval measurements, the intervals are regular. What's going to be very critical here, though, is measuring your PR interval. If you can measure the PR interval, in other words, if the P wave precedes the QRS, the PR interval is going to be less than 0.12 seconds. That's very critical. The QRS is going to be normal, the R to R, and the QT is normal. There's no real relationship if you can't see the P waves. If you can see the P waves, there's going to be a one-to-one relationship, and the heart rhythm itself is going to be regular. So here's a good example of a junctional rhythm. If you look at this rhythm, you can see the first thing that I notice about it is there are no P waves. You've got totally an isoelectric line going along here, and there's no P wave whatsoever before any of these QRSs. Okay, so if you look at our criteria, our heart rate, the rate is 40 to 60 because that's the inherent pacemaker rate of the AV junction. The rhythm is regular. The P wave can be inverted, absent, or after the QRS. The PR interval, this is critical, is less than 0.12, and the QRS is typically normal. It's going to be less than 0.12 in width. So let's talk about our causes for junctional rhythms. Number one cause that we talk about is an MI, and it's usually an inferior MI. And if you think logically about why that is, if you remember, if you look at the way the SA node is supplied in terms of blood, the SA node is supplied by the right coronary artery, which is typically more inferior. And so if you have an inferior MI and you have some type of damage to that right coronary artery, or you don't have perfusion in the right coronary artery, you have damage to the tissue that's perfused by that, the SA node is one of those. Cardiac surgery can cause junctional rhythms. Digitalis, there's our dig again. Love that drug. We're going to talk a lot about it here in a few minutes. Sinus node dysfunction, significant vagal stimulation, hypokalemia, sick sinus syndrome. We talked about that on our sinus rhythms, and essentially something's wrong with the SA node. You can have valvular disease, AV block, hypoxia, as always, can cause it, and meds can cause it, digoxin, beta blockers, and calcium channel blockers. So what are our treatments and our ramifications if we don't treat? First of all, you're not always going to treat a junctional rhythm. It's usually not necessary, and certainly not if they're asymptomatic. You need to identify and treat the underlying cause. For instance, if you've got medications that are slowing the sinus rate, you need to discontinue those medications or decrease their dosage. You need to fix electrolyte imbalances. You may need atropine if the patient has a heart rate that is really slow and they're symptomatic. You may need a temporary or permanent pacemaker, but in general, junctional rhythms are usually associated with a benign course. There is always, when you have a slower heart rate, even if it's sinus or junctional, no matter what the reason or what the pacemaker is, any type of slow heart rate can result in reduced cardiac output. Junctional is a little bit more likely to result in a reduced cardiac output, even obviously than a really slow sinus bradycardia, because if you think about it, one of the issues is you're not going to get a great atrial contraction with a junctional rhythm because you're not depolarizing the atria in the correct manner. So that synchronicity between the depolarization of the atria, atrial contraction, and then depolarization and ventral contraction, that synchronicity is a little bit off. The nursing implications of junctional rhythms, you need to assess comfort and signs of palpitations, any type of symptoms of decreased cardiac output, and hemodynamic compromise due to loss of the AV synchrony that I just talked about. Evaluate their heart rate, their blood pressure. We've talked already in the past about LOC, making sure their level of consciousness is good. You want to assess the fall risk. They're obviously going to be monitored cardiac-wise on cardiac monitoring. And we're going to monitor digoxin levels if they're on dig, and we want to take a look at their potassium and magnesium levels and their caffeine intake as well. So here's a great example of a junctional rhythm. If you look at this particular rhythm, you can look at your R to R's here, and I'm just going to count these backwards: 300, 300, 150, 100, 75, 60, 50. So this rate is going to be between 50 and 60. We could do a 6-second strip also. 1, 2, 3, 4, 5. We're going to come up with around 50. If you look at the isoelectric line here, you don't see any P waves at all. There are no P waves there. So you have a rhythm that's very regular, but we don't have any P waves. And if you remember junctional rhythms, the P waves can come before, during, or after the QRS. The key is if the P wave were to come before, most likely it's going to be inverted or it's going to look different, and you're going to have a decreased PR interval. This one, you don't see a P wave at all. You've got a QRS and a normal T wave. So this would just be called junctional rhythm. Here's a great example. If you look at this particular rhythm, you can see the inverted P wave before each QRS. So you've got an inverted P wave before each QRS. Your R to R looks to be about, let's see, 1, 2, 3. We're gonna do 6 seconds here. So you've got a rate of about 50. You've got an inverted P wave, and if you measure out that PR interval with that inverted P wave, it's going to be less than 3 boxes, so it's going to be less than 0.12. Your QRS looks pretty normal, and you've got your T wave looks like it's a little upside down, basically. But the key here is the inverted P wave, and the PR interval is less than 0.12, and the rate is between 40 and 60. So that's a junctional rhythm. So last week, you guys should have learned about PACs, premature atrial contractions, or premature atrial complexes. And this week, we're going to talk about premature junctional complexes, essentially the same thing, except it's going to have the same characteristics of the junctional rhythms regarding P waves. So premature junctional complexes, here's an example of a PJC, and you can look, they're circled in red, but if you look at the normal QRS here, the normal QRS has a P wave, normal QRS, T wave. Here's one, there's a normal one, here's another one with a good P wave. Okay, you can see those are all sinus beats, essentially, originating from the SA node. But what happens is that when we march out the QRSs, we have a complex circled in red here that comes in early. That means it's premature. It's an early beat that occurs before the next expected sinus beat. Okay? It looks like a PAC, right? But in this particular beat, the P wave is inverted. The P wave's inverted, and our PR interval is less than 0.12. So it comes in early, and we have an inverted P wave with a PR interval less than 0.12. So we're going to call that a PJC. So a PJC interrupts the underlying rhythm by occurring earlier than the next expected sinus beat. Our best leads for monitoring those are in 2, 3, and V1. The heart rate is going to be the rate of what the underlying rhythm is. And then the P waves are inverted and can occur before, during, and or after the QRS complex, or can be completely missing, which really they're occurring during, because we're not going to see them if the P waves are occurring during the QRS. The QRS is usually normal in shape and duration, 0.04 to 0.1, unless there's some type of intraventricular conduction abnormality, which you guys are going to talk about later on down the road. And our T wave is normal. Our PR interval is only measurable if the P wave occurs before the QRS, and then the PR interval is less than 0.12 seconds. The rhythm is actually going to be irregular, mainly because of the PJC. Otherwise, it's a pretty regular rhythm. The PJC, it's premature, it's coming in early, and it makes it irregular. The relationship of P waves to QRSs are 1-to-1, except for the PJC has that unusual P wave that's inverted, or you may not see a P wave at all. Here's another example of a PJC. You can see here we're going along right through here. We've got these sinus beats going along, 1, 2, 3, 4, and then all of a sudden we have a beat that comes in early. Look at the difference between the P wave on these sinus beats and this beat over here that came in early. There's no P wave at all. If you come over here, you've got 2 more sinus beats and then something with no P wave at all. So what you have is you have a beat that's coming in early and it does not have a P wave, and the QRS looks normal. It looks like all the other QRSs. So we've got a PJC. And the rate on this probably, it looks sinus. So that you would call this a sinus rhythm with a PJC. Here's another example. If you're coming along here, you've got a nice sinus beat with a P wave. Here's a nice sinus beat with a P wave. These are all sinus beats with P waves. But if you measure your R to R out, this particular complex here is coming in early, okay? And not only is it coming in early, you can see that the P wave is inverted. And if you looked, it's hard to see in this particular strip, but this is a short PR interval also. Now the QRS looks exactly the same as the QRSs from the sinus beats because it's traveling the same route down the ventricles. So you have the same looking QRS, but basically you are starting your pacemaker, your PJC is starting in the AV junction, and you're getting retrograde conduction up through the ventricles, and that's why you've got that inverted P wave. So again, you would call this a sinus rhythm with PJCs. It looks like there's 1, 2 PJCs there. Here's another example. You've got, if you take a look at, here are sinus beats right here. You can see nice P waves, nice slender QRS, T, P, QRS, T wave, and then all of a sudden you have this beat that's coming in early. This is coming in before the next sinus beat would be expected. Not only is it coming in early, but you don't really see a P wave. And we know that there's no P really occurring in that T wave right before it, because that T wave, this T wave looks the same as this T wave. So there's nothing in there. Now, if you look really closely here, you do have a small inverted P. And let me erase this so you guys can get a better look. But you have a small inverted P there, and it comes in early. Your PR interval is less than 0.12. So again, you have a sinus rhythm with a PJC. And then one more example here. We've got nice sinus beats here, And then all of a sudden we have an early complex, an early QRS complex. If you look right before it, there is no P wave visible, but everything else looks exactly the same. That is an early beat, it's a PJC. Why is it not a PAC? Because it's not coming from the SA node. There would be a normal P wave and a normal PR interval to a PAC. So since PJCs are considered, they're sort of considered excitatory, they're early, they come in early, they're not an escape rhythm, which we're going to talk about later. It's something that's irritable in the heart. The causes of PJCs can be caffeine intake, DIG toxicity, heart disease, chronic lung disease, and of course we always get into our electrolytes, hypokalemia, sinus node dysfunction, or acute inferior MI. Manifestations and management. A lot of times patients will complain of palpitations. They feel like their heart may be skipping a beat or their heart feels funny. We typically don't treat these. We identify and remove the cause if there's something pathological going on. It's possible for a PJC to initiate a more serious arrhythmia, like an AV nodal reentry tachycardia. But again, we generally do not treat the PJCs in and of themselves. So the nursing implications, we're going to assess the patient for palpitations, evaluate for signs of decreased cardiac output or any type of hemodynamic compromise. Those things are like hypotension, angina, crackles in the lung fields, an S3 heart sound, decreased urine output, changes in mentation, diaphoresis. Those are the types of things that we look at when we're looking for decreased cardiac output. You can count the pulse for 1 minute to differentiate this from a sinus arrhythmia. And then monitor the digoxin levels, potassium and magnesium, monitor caffeine intake, inform patient and family of any dysrhythmia that is found, and explain any intervention for nursing implications. Now we're going to go sort of to the opposite end of the spectrum. We talked about PJCs being very irritable and coming in early. The impulse is coming in early. It's very excited. It wants to generate early, basically. The opposite of that is a junctional escape beat. A junctional escape beat comes in late, and its purpose essentially is to save the heart. We have junctional escape beats, and as you'll find, we have ventricular escape beats. So in other words, the SA node is going along and firing at its normal rate, and then for whatever reason, we'll talk about different reasons. Let's say we get a huge vagal stimulation, and for what that impacts the SA node, and the SA node just does not fire within a timely manner, then the AV junction is going to come up. The AV junction is going to come in and take over the pacemaker firing of the heart. And it's going to do that with a junctional escape beat initially. And you can see in this particular strip here, you've got a couple of sinus beats, then you've got a really long pause. And so the beat that comes in next is late. It's not early. That's what makes it an escape beat. Additionally, there's no P wave, or if you want to call that tiny little thing a P wave there, you can call it a P wave, but it's inverted and it's way too close to the QRS. So there's a PR interval less than 0.12. So what you have here is probably a sinus. Over here it almost looks like a sinus Brady. Here it looks like a sinus rhythm rate-wise. A sinus rhythm with an escape junctional beat. So junctional escape beats, it's a single beat originating in the AV junctional tissue of the heart. It falls later, not earlier, falls later than the expected sinus beat. It prevents cardiac standstill when the SA node doesn't fire. The best leads for monitoring this are 2, 3, and V1. So if we look at the heart rate, that's determined by the underlying rhythm. And remember when we looked at the EKG the escape junctional beat on that EKG strip, I said initially it looked like we had a sinus brady rate-wise, and then when we came out of it, it looked more like a sinus rhythm rate-wise. So the heart rate is determined by the underlying rhythm. The P waves, they're inverted before, they can be during or after the QRS, or could be totally missing. The QRS is normal, 0.04 to 0.10 seconds, normal configuration and duration. The T wave is normal. So if you have a PR interval, if the P wave occurs before the QRS, the PR interval is less than 0.12 seconds. The rhythm is regular except for the junctional escape beat, and the relationship of P waves to QRSs is 1-to-1 except for the junctional escape beat. So let's take a look at this rhythm. Let's figure out what the rate is here. So the rate, if I'm going to count lines here: 300, 150, 100, 75, 60, 50. So between 40 and 50 is the rate right here. So you've got a sinus brady coming along here. You've got these P waves with QRSs and T waves, and then all of a sudden you have a long pause, you have nothing happening in here, and then you have a beat that comes in that the QRS and the T wave look the same, but there's no P wave with it. So that means it's an escape junctional beat. Escape junctional beat. Another example is you've got an escape complex. It comes later than the next expected sinus complex. And you can see those escape beats. They have the arrows on them. They're coming in later than expected. An ectopic junctional beat that occurs late within an underlying rhythm. The P wave will be inverted if it's before the QRS, hidden within the QRS, or late and inverted if it's after the QRS. So causes of junctional escape beats: increased vagal tone, sick sinus syndrome, SA node ischemia, which we've already talked about, occurs in inferior MIs, valvular disease, AV block, cardiac surgery, medication toxicity, including DIG, quinidine, beta blockers, and calcium channel blockers. Our manifestations and management. First of all, as with any rhythm, we're looking for symptoms of decreased cardiac output, which dizziness, syncope, hypotension. Usually with an escape junctional beat, there's not any treatment necessarily indicated, but what we're probably going to end up doing is increasing the rate of the highest pacemaker and removing the possible causes for the pause in the rhythm. So we would like to increase the rate of the SA node. Why is the AV node having to come in and take over? Is it because I have too much DIG in my system? Is it because I'm taking too much of my beta blocker? But we want to assess the hemodynamic status and the ramifications. If not treated, they can have a possible junctional escape rhythm, ventricular escape rhythm, or third-degree AV block. The nursing implications: these patients can be a fall risk. You need to teach the patient to call the nurse if they experience any dizziness and to request assistance to get out of bed or ambulate. And as we always talked about, assess their blood pressure, their heart rate, level of consciousness, and dizziness for signs of decreased cardiac output. So the next junctional rhythm we're going to talk about is junctional tachycardia. In junctional tachycardia, you can have a rate between 650 all the way up to 250. Here we're talking about non-paroxysmal AV junctional tachycardia, or we're talking about accelerated junctional rhythm, and we'll distinguish between the two. The discharge impulse is actually near the bundle of His, and it supersedes the sinus node rate. So that's where we get the tachycardia. Here's an example of a junctional tachycardia. As you can see, we've got a rate, let's see here. Let's look at something that's on the line here. I'll look here. So there's 300, 150. So it's between 100 and 150 essentially. And if you look at the P's on it, you can see the P's are inverted. Your PR interval is going to be less than 0.12. So this is going to be called a junctional tachycardia. Here's another example of a junctional tachycardia. And this one you can see the P wave is right on top of the QRS basically. You can't even really measure a PR interval. The rate looks like it's about close, a little higher than 150 maybe, around 160. So that's another junctional tachycardia. And if we look at the characteristics of junctional tachycardia, the impulse at the bundle of His discharges at a rate that supersedes the sinus node rate. The best leads for monitoring are leads 2, 3, and V1. And the heart rate typically runs from between 60 and 150 beats per minute. It can go all the way up to 250. If it's 60 to 100, if the rate is 60 to 100, we call it accelerated junctional. If it's 100 to 150, sometimes all the way up to 250, we call it junctional tachycardia. But it has to have the following characteristics. Your P waves are inverted before, they may be during or after the QRS or just totally absent. The QRS is normal, 0.04 to 0.10 seconds, and the T wave is normal. When we look at the rhythm, it's regular, and the PR interval, if the P wave occurs before the QRS, then the PR interval is less than 0.12 seconds. And the relationship is, there is no relationship. It's not one-to-one unless the P wave does occur before the QRS, which then will make it one-to-one. So I keep telling you that the P wave can come before, during, or after. And if it comes during, obviously it's absent. We don't see it. If it comes before, it's typically inverted and the PR interval is less than 0.12. Well, here's a great example of the P wave coming after the QRS. So here we've got a junctional tachycardia. We've got a heart rate of about 120. We've got a regular rhythm, but our P wave is after the QRS. Look at that P wave there. And it's inverted, again, because we've got retrograde conduction when we depolarize those atria. The QRS here is 0.08. The PR interval is not able to measure essentially because the P wave's not before the QRS. So there is another junctional tachycardia with an example of a P wave following the QRS. Here's an example of an accelerated junctional rhythm. An accelerated junctional rhythm is when we have a junctional rhythm that is between the rate of 60 to 100. And so if you think of it in terms of equivalency, if you think of sinus, we've got sinus bradycardia, which is less than 60. We've got normal sinus rhythm, which is between 60 to 100. And we've got sinus tachycardia, which is greater than 100. With junctional rhythms, remember, our junctional rate is slower than our intrinsic sinus rate. So with junctional rhythms, we have junctional rhythm at 40 to 60. Accelerated junctional is going to be from 60 to 100, and then junctional tachycardia is going to be over 100, basically. In this particular strip, we have no P waves at all. No P wave can be seen. We have a rate of about 92. It's a regular rhythm and an absent P wave. The QRS is normal and the PR obviously is not measurable because there's no P wave. We call this an accelerated junctional rhythm. And just for clarification on the accelerated junctional rhythm, the heart rate is between 60 and 100. The rhythm is regular. The P wave can be inverted, absent, or after the QRS. The PR interval is less than 0.12, and the QRS typically is less than 0.12. It's typically normal. So what are the causes of junctional tachycardia? And again, if you think of this more along an excitatory impulse, because it's going faster than what the intrinsic rate of the junction is. Junctional tachycardia is faster than 40 to 60. So one of the most common causes of junctional tachycardia, believe it or not, is digitoxicity. Inferior MI, cardiac surgery, viral or rheumatic myocarditis, hyperthyroidism, hypokalemia. A very common cause is reperfusion after thrombolytics. So if they've given TPA and they've got reperfusion of a coronary artery, that's especially associated with accelerated junctional rhythm. It can be idiopathic. In pediatrics, it can happen after operative repair of congenital heart defects. It rarely occurs in absence of underlying heart disease. The manifestations can be just manifestations of decreased cardiac output. Once again, if we're talking about a junctional rhythm, we're not getting the normal depolarization of the atria, and therefore we're losing our atrial kick, which may not be a big deal to a young, healthy person, but it's a big deal to someone who's already compromised, somebody who already has some cardiac issues. So we may have manifestations of decreased cardiac output like hypotension, dizziness, syncope, chest pain. We may have no manifestations whatsoever. We need to look for an underlying cause here. So what are our treatment options? We said one of the most common reasons that we see junctional tachycardia is digitoxicity. So we're going to discontinue our digitalis. We're going to determine the cause, support the cardiovascular system. If the patient is hemodynamically compromised, we want to suppress this junctional pacemaker. And otherwise, we have this rapid response. We have this rapid rate going on, and we want to slow that down with a beta blocker, a calcium channel blocker, or an amiodarone. And if we're talking about digitalis toxicity, we may end up having to give Digibind, which is an antidote to digitalis toxicity. The nursing implications, we want to assess for signs of decreased cardiac output, figure out what is the underlying cause, IV access and monitor with telemetry. All of these patients that have cardiac issues are going to get 12-lead EKGs. If it's a digoxin issue, we're going to withhold the digoxin. I can't pronounce it for some reason. And then we're going to teach patient how to take the digoxin appropriately and the dangers and symptoms of digoxin intoxication. The next thing we need to cover in this lecture is we want to discuss the concept of re-entry as it applies to cardiac conduction. The concept of re-entry impulses. This is an abnormal situation that people have congenitally. They have congenital issues with their heart, and they have two functional or anatomic pathways of conduction. They have an area of slow conduction, and this one area can have, this one pathway can be slow conduction, fast recovery, and the other pathway is fast conduction, slow recovery, and there's an area of a unidirectional block. This is a really complicated concept to understand and to wrap your head around. So what I've done is I'm going to show you a diagram here, and we're going to look at what normally happens in someone who has these pathways. So once again, this is an abnormal situation, a congenital problem in someone's heart. So it's abnormal that they have these accessory pathways. But even though it's abnormal, in the normal situation, in other words, if we're talking about what happens in these patients in just a regular normal sinus rhythm, you have an impulse. Think of it as the impulse here is coming from the SA node, and it's going down both pathways. It's going down the slow pathway here, and it's going down the fast pathway over here. And when it reaches this intersection, the impulse is going to travel two ways. It's going to continue down through the bundle of His into the ventricles, but it's also going to travel retrograde. If it runs into another action potential here, or another electrical impulse, they essentially cancel themselves out. So there's no issue there. You have an impulse that comes down, it's going to excite both of these pathways, but in the normal situation, only one impulse is going to go down to the ventricles, and the other impulse is going to essentially cancel out. However, as you will see in the video that I've got on the next slide, what's critical about re-entry are refractory periods and when impulses hit during refractory periods. So if you have an early impulse that comes down, a PAC, essentially what you're going to have is this early impulse coming down, and you're going to try to go this way. You're going to try and come around the normal way, which is the fast conduction way, but it's in a refractory period right now. So that impulse is not going to be able to travel the normal fast pathway. It's going to end up going around this slow pathway. What happens in this next picture is because this electrical impulse is coming down sort of this abnormal pathway, it's going to go here and go on down to the ventricles, but it's also going to circle back around and come back up retrograde. And because of the timing that this impulse hits this fast pathway, it's going to be able to travel in a retrograde manner. And essentially what begins is what we call a re-entry circuit. And this is picture number 3 over here. So you have a re-entry circuit going in a circular manner, and you have impulses going retrograde back up to the atria and impulses going down to the ventricles. And this occurs in a very rapid manner. The best way, or the best thing that I've found to explain this, is a video that I've included on the next slide. So I encourage you to click on this video, and it uses the analogy of cars on a bumpy road and cars on a nice smooth road. And it really helped me understand the concept of re-entry circuits. Remember, they're very, very dependent on and associated with refractory periods, your slow and your fast conduction pathways, and the action potentials that are either being generated, or if two action potentials run into each other, essentially they cancel each other out. So those are the concepts that you need to understand in order to understand cardiac re-entry circuits. So go ahead and watch that video, and then we'll move on to the next slide. So the reason that the concept of re-entry circuits is important is because we're going to talk about different types of supraventricular tachycardia arrhythmias. This one specifically is called a paroxysmal supraventricular tachycardia arrhythmia. Paroxysmal means sudden, supraventricular means coming from somewhere above the ventricles, and tachycardia is an abnormally fast heart rate. So if you look at tachycardias, a category of sudden onset tachyarrhythmias caused by a very irritable focus located somewhere above the ventricles. These arrhythmias are most commonly triggered by the re-entry phenomenon that we just talked about. And flavors of PSVT include paroxysmal atrial tachycardia, paroxysmal junctional tachycardia, AV reentrant tachycardia, that's seen in Wolff-Parkinson-White syndrome, and AV node reentrant tachycardia, among many others. But AV node reentrant tachycardia is what we most commonly refer to as PSVT. So this reentry phenomenon, this rapid reentry, this circular reentry phenomenon is causing what we call PSVT. The findings on PSVT, we're talking about a heart rate between 150 and 250. The heart rhythm is regular. The P waves, we're not going to be able to see those. They're absent, essentially. If we can see P waves, we can call things sinus, but in PSVT, it's so rapid that we cannot identify P waves. They're absent. The QRS wave is regular. This is very important. It's also narrow, because if it were wide and this rapid, we're going to be calling it something different. We're going to be calling it ventricular tachycardia versus PSVT or supraventricular tachycardia. The T waves are present, but they hide the P if there is a P wave present at all. The waveform relationship is regular. Our intervals, our P to our QRS is 1 to 1, although again, we typically are not going to see Ps. The PR we can't discern. The QRS is going to be within normal limits. It's not going to be wide. It's going to be less than 0.11 or less than 0.10. And the QT is going to be within normal limits, less than 0.44. So our best leads for PSVT 1, 2, 3, together with V1 and V6. Our rhythm can be irregular at the onset. If you remember, we talked about paroxysmal. It's a sudden start and sudden stop. But when it initially starts, it can be just a tad irregular, but then it's going to be regular thereafter. The heart rate is going to be 150 to 250. The P wave not present or discernible. The PR interval is not measurable. The QRS complex is normal. It says it may be a little wide if abnormally conducted through the ventricles, but if it's wider than 0.12, then we're going to call it a different rhythm. The T wave is upright if we see it at all, and the QT interval is very difficult to measure. So here's an example of PSVT. You can see up in this top one here how we're going along, and this is what it's talking about. Right here, you can see just a tad of irregularity between those 3 beats there before it actually starts. So we have a rhythm that's going on here that's about 300, 150, 100. So between 75 and 100 are between these 2 beats. And then all of a sudden, we're in a rapid rhythm. PSVT, we can't identify any P waves at all. And we're going to call that paroxysmal PSVT. Here we can just call this SVT. We don't see the stop and start, the sudden stop and start here. We can call this SVT. There are no P waves present. You can see it's very regular. The QRSs are very, very narrow. And then once again down here, same kind of deal. We've got a rapid rate. It's greater than 150. It's very regular. There are no P waves discernible. How are you going to differentiate this from atrial fib? Atrial fib is always irregular. You don't see P waves in atrial fib either, but your atrial fib rhythm is always irregular. SVT and PSVT is always regular. Here's a great 12 lead with SVT, and we're talking about 203 beats per minute. You can see the rate at the very top. So what are the causes of PSVT? The atria and junctional foci become irritable for several different reasons. It can be due to adrenaline or epinephrine release by the adrenal glands, increased sympathetic stimulation, presence of caffeine, amphetamines, cocaine, or other beta-1 receptor stimulants, excess digitalis, some toxins, sometimes alcohol, hyperthyroidism. It's a direct stimulation, plus the heart is oversensitive to adrenergic stimulants, stretch, and to some extent low O2 or hypoxia. Other causes, you can have premature beats, atrial or junctional. Remember we talked back on the PJCs that a PJC can maybe lead to a reentry circuit or maybe just essentially the start of a reentry phenomenon. Stress, overexertion, deep inspiration, and then disease states like coronary artery disease, rheumatic heart disease, right heart failure, history of an MI, hypoxia, hypokalemia. So our manifestations and our management, the signs and symptoms may or may not be present. It typically depends on how rapid the heart rate is. If the symptoms are present, typically the patient is going to complain of palpitations. That's the most common thing. Hypotension, dyspnea, angina, dizziness, weakness, fatigue. What are we going to do? We're going to try to stimulate this parasympathetic nervous system. Excuse me, we can do that with vagal maneuvers. You can have patients Valsalva, blow through a straw, try to blow into a straw. You can have them splash their face with ice water. And carotid massage is something that has been done in the past to try and get the parasympathetic nervous system to come in and sort of slow this down, slow this excitability down. We can use pharmacological treatment. IV adenosine is the #1 drug that we're going to use for an SVT. IV calcium channel blockers, IV beta blockers, amiodarone are other drugs that we can use. And then additional treatment, if we have a patient that's extremely compromised, we're going to synchronize cardiovert them. And they're eventually going to be treated by radiofrequency catheter ablation, where they go in and they map out these accessory pathways and they ablate them. So what are the ramifications if we don't treat this PSVT or SVT? What if we don't treat this rapid heart rate? In a structurally normal heart, it's an excellent prognosis. It's going to be fine. This patient is typically going to end up getting an ablation, basically to try and knock out those accessory pathways and decrease that reentry phenomenon. In the setting of cardiac dysfunction, especially in left ventricular heart failure, or especially in left ventricular dysfunction, you can have heart failure, pulmonary edema, tachycardia-induced cardiomyopathy, myocardial ischemia, or infarction. So anyone that is compromised, it's going to be much more dangerous, obviously, for their heart to be beating at this rapid rate, because not only does it require a tremendous amount of oxygen, it also decreases your cardiac output once you get up to those rapid rates because you don't have filling time. What are the nursing implications for SVT or PSVT? First of all, patient teaching. You want to teach them how to count their heart rate. You want to teach them when palpitations are felt, how to perform vagal maneuvers, carotid stimulation, and to go to the hospital if the palpitations continue. Don't smoke cigarettes, monitor caffeine intake, don't do recreational stimulants such as cocaine or amphetamines. Many episodes of PSVT will stop on their own. However, they should seek medical treatment if the patient is dizzy, lightheaded, or weak. So here's an example of PSVT. Note the sudden change from regular rhythm to irregular rhythm. So that's what it's talking about when you're going from this slower rhythm here This is sort of the slower rhythm, and then it becomes irregular at this point. But as they stay, the longer they stay in the PSVT in the rapid rate, the more regular it's going to become. Another example of PSVT, you can see where it's initiated here. You see we're going along right here. We've got sinus beats here. You can see the P waves, and then all of a sudden we're in a really rapid heart rate of about, does it say 300? 167 initially, but this is much faster. You can see that's probably going to be a rate of around 250 to 300 in that fastest part. Here is SVT. You don't see the stop and start, so we're going to call this SVT, okay? You don't see the sudden stop and start. So you've got a rapid rate here of about, it's over 150. There are no P waves. We're going to call this SVT. And then here's a great example. Here's a recording of a patient who was in SVT, and they gave adenosine, and then they converted to sinus. So they're going along here. They look like, if you look at the rate up here, it looks like a little bit less than 150, but there are no P waves. So there are no P waves here. They're going along. They give the adenosine right here, and it says 12 milligrams of adenosine. And adenosine is given, it has a really fast half-life. So you have to give it IV push and you flush behind it. So all of a sudden you've got these funky beats coming in here that look almost a little, there's a, that looks like a normal QRS, but you've got sort of some opposite deflection, looks like maybe some ventricular beats. Basically the heart, the medicine is trying to stop that ectopic focus. And then you get a conversion down here. You can see where the SA node comes in and takes over again, and you've got a sinus rhythm basically. So this is just an example of SVT with adenosine treatment. That is all the slides I have for junctional and SVT. I look forward to seeing you guys on Friday. Thanks so much.